Welcome to the Opiate Crisis Impact on Families and Children, Part 2. I'm Tim Schaffner. I'm Director of Trumbull County Children's Services in the Northeast area of Ohio. Prior to my entry into the child welfare field 7 years ago, I spent several decades in community mental health and inpatient psychiatry. This is Part 2 of Impact on Families. Due to the opiate crisis, Part 1 is available through wraparoundohio.org. In Part 1, we talked about the Ohio being at the forefront of the opiate crisis. If you look at a map of the United States, you will see that this area of Ohio, West Virginia, and Pennsylvania is a hotbed of opiate use, opiate death, and the impact on the families. Families have been impacted by this opiate epidemic at unparalleled rates in modern times. We, of course, have always had alcoholism and other impairing substances having impacts on the family, but we have really not seen a level of overdose deaths that we've seen. And as we talked about at length in Part 1, the difference in the onset of the disease and the difference in how rapidly use is increased and impairing with this particular disease. Besides the immediate effects on children with their parents being impaired, the lack of attunement and the impact on attachment was also discussed in the Part 1 of our Impact on the Family series. We can see and will be seeing some years into the future the impact of this lack of attunement and attachment challenges that kids are experiencing because of this. And finally, we talked about the fact that routine interventions may not be adequate to meet a child and family's needs. We wonder how many routine diagnostic assessments of children and their parents include measures and tools, instruments to measure attachment. We wonder how family interventions and parenting programs have been able to shift from talking about family routines and limits and discipline to how to play with your kids, how to reestablish attunement and relationships with the child that are age appropriate for the child. Our objectives for Part 2, we want to complete an overview of Part 1, Impact on the Child, so that we can provide the best link to our comments in Part 2. We want to provide a current update on the opiate crisis impact on families and the resulting impact on children. Things are changing. There's some positive changes, and there are remaining issues that we need to talk about and we need to address. And then we want to talk about an overview of interventions from a system of care, agencies, programs, individuals, and communities, because it really does take a whole village, particularly when there's a crisis at hand. As I referenced before, if we look at a map of the United States, we can see that Ohio, West Virginia, and Pennsylvania are the hotbeds. Certainly, there are economic reasons, there are social reasons for this. That's for another subject. What we do know is that beginning in 2012, 2013, in Northeast Ohio anyway, we began to heavily feel the effects of this in child welfare. So on the trending slide, unintended opiate deaths are trending down in most communities. That's the good news. In my community, our Consolidated Health District Department holds regular opiate task force meetings where we not only measure the impact of the crisis, the flow of substances on the street, but also create action plans with how, as a community and as community agencies working together, we're going to deal with this. So the first takeaway is there hasn't been heroin in this community or in most communities for months. Heroin has been effectively replaced by fentanyl and other synthetics. It is cheaper to produce. It is more efficiently delivered to the dealer or the user, and it really effectively, in terms of the economy of substance sales and use, it has cut out the middleman in several ways. The problem with that, of course, is that fentanyl production and its impact and effectiveness varies widely and cannot be measured by the user in the streets. More good news, there are less opiates being dispensed by medical providers in our community and many others in Ohio. There have been concerted efforts to find alternative methods of pain relief, and just pointing out that overprescription leads to addiction, and the opiate crisis has effectively begun to reduce dispensing of opioids. It used to be automatic in many areas to receive a large prescription of Vicodin after serious dental work. Those types of things never happen anymore. More good news. Almost all first responders carry naloxone, Narcan, so that we have earlier intervention. It's more complicated by the varying levels of Narcan, of fentanyl and its strength, but it is carried, and we can, as we increase the first responders carrying Narcans in our community, we can see a consequential decrease in deaths by unintended deaths by overdose. More good news, we're seeing increased availability of medically assisted treatment, MAT, like buprenorphine, and the responsible prescriptions and involvement in other treatment programs when MAT is used. On the downside, we're seeing in our community and many others an increase in use of other substances like crack cocaine and methamphetamines. Opiate users early in recovery are reporting that many current users are switching to other substances to avoid unintended overdoses. Unfortunately, fentanyl has entered that drug stream also and is causing unintended deaths. While deaths are decreasing, use of illegal substances, rapidly impairing substances, continue to impact our citizens and communities. As we said before, the use of crack cocaine, the use of methamphetamines, and of course the use of alcohol continue to be a scourge in most of our community. High rates of children in public children's services custody continues to increase. While the deaths are going down, the impact of addiction on people's ability to parent continues to be a dynamic that we have to address daily in our community. And the consequences are that children in our custody continue to be younger, they continue to be in care longer, and they continue at higher levels of care. So, because we have younger children, they're in the system for longer, they're at higher levels of care, we have a severe strain on our system. Our foster parent placements are full to overflowing. Even in communities like my own, where we have a wonderful foster system of between 70 and 80 foster families at any one time, they're often full. This necessitates sending kids to higher levels of care, farther away from home, which complicates reunification in ways that wouldn't occur if we had an adequate foster care system. Our higher levels of care are also full. This is due to the rapid influx of new children into the system. This is due to a system that had, in the last several decades, moved away from the more intensive levels of care, so that we have reduced capacity in Ohio in the last 30 years, leaving us rather unprepared for this. At this presentation, there are 140 youth placed outside of Ohio in residential treatment due to this lack of capacity. Now, this is being addressed. It's being addressed by the Ohio Children's Alliance, by the Ohio Department of Job and Family Services, and I would refer you to the Public Children's Services Association of Ohio's Children's Continuum of Care Reform Plan. So plans are in the works. We are responding, but to move systems take time. Until that time, kids are going to be in levels of care that aren't necessarily appropriate for them. Funding in Ohio has traditionally been very low in terms of the amount of money sent to local child welfare from the state. And our mantra has always been, compared to the other 49 states, Ohio is 50th in terms of the amount of money contributed to local child welfare efforts from the state. Our current and new administration has made a huge commitment to change in this area, and everyone in the system is very hopeful that this will occur and will be helpful. Person impact. For most of us, the shock of more kids in care, younger, higher levels of care for longer, took a few months to respond to. What many of us got very good at 24/7, 365 when the crisis occurs is to connect with kin. And kin, especially grandparents, have really stepped up to the plate to take care of the children in need. Remember, these are families who have probably already experienced a huge loss in the loss of the parent of the children that they've taken into their homes. So this is a huge challenge for these families, and we have utmost respect for them for stepping up and taking care of their families when in need. This becomes a challenge also frequently at 10 o'clock at night when we're involved in an emergency situation with the police. As we look for family members, we're continuously startled by how this epidemic cuts across generations of families. So mom's mom is also addicted to opiates. Aunt Judy is addicted to other substances, and it's shocking to the system, and it's shocking to the people looking for help. Generally, we've been increasingly able to find appropriate kin to take care of children. Finally, in terms of the person impact, our child welfare workforce is experiencing what they've never experienced before. Never before has the child welfare caseworker in the field experienced so much death of parents and other loved ones. The extreme impact on the children that they're working with and may have to take into emergency custody. This results in a turnover rate in many communities over 25%. It is extremely taxing on county public children's services agencies. When there is a high turnover rate, that results in higher caseloads for the remaining caseworkers. That results in higher stress and just more challenges to delivering the life-saving services that we deliver. And maybe even more significantly, we're seeing higher rates of secondary trauma. Ohio recently received a quality improvement grant from the feds, and surveyed 1,000 caseworkers around Ohio. And part of the survey looked for some of the items on the decision tree for post-traumatic stress disorder, and discovered that the rates of PTSD are more than double the rates we see in other first responders, something that we drastically need to respond to take care of the people that take care of our citizens. So let's review the developmental impact on children of parental use of opiates and what the long-term consequences are. So it's important to remember the opiate addiction comparison, what has caused our systems to take time to adjust to this new substance being used. We know the progression is faster. We know that it takes an alcoholic years to progress to the point of 30 beers a day or 2/5 of hard liquor a day. The progression to high dosages of opioids is very rapid, days or weeks. The dosing is frequently higher and variable, so the persons that are addicted to opioids have a really unreliable source and unreliable information on the substances that they're using. Impairment through the use of alcohol is gradual throughout its use in a particular day. Impairment is immediate with opioids, affecting parents significantly differently. The cost, there's a cost difference. This puts severe financial strain on families when there's opioid use in the family. And fatal overdose continues to be common, not at the same rates that it was, but even with the shift to crack cocaine, other cocaines, and methamphetamines, we continue to experience sudden unintended death. So if we look at what the parenting condition is in the 4 stages slide, with a parent who is addicted to opioids, there are really 4 conditions. They're drug sick, in need of a fix, finance seeking, and there are a variety of ways, as we all know, to obtain the finances necessary to support this kind of a habit. Most of them illegal, many of them placing them in proximity with other adults that we do not want our children to be exposed to. Then they're drug seeking, and finally they're impaired. The results of this total focused attention on this particular addiction leads to a consistent lack of attention and attunement to the child. And it's sudden attunement. It can occur when the rapid progression of this illness happens, and it can be at any age of the child. And the age of the child, with the onset of this addiction, will affect their attachment differently. So the developmental impact of this sudden, extensive lack of attunement and the dynamics that arise in the household can lead to serious attachment challenges. So most modern researchers into attachment no longer believe that attachment is firmly established forevermore between the ages of 12 and 30 months. It is more generally seen as a changing dynamic based on the life experiences, even into adulthood, according to some theorists and researchers. But here's what we know now, that this sudden progression into a disease that involves sudden lack of attunement to a child can lead to these attachment challenges. And on the slide, you can see challenged attachment. Ambivalent attachment, relationships are important, but a lot of times behaviors are developed that might be inappropriate and unacceptable in neighborhood and school settings. as the child seeks alternative relationships when none are available at home. Avoidant attachment is when relationships aren't valued by a child. There are behaviors that can be developed that are resistant to relationships and in that way self-protective. And finally, disorganized attachment. That's the result of lack of attunement and also danger in the environment. So we end up with a child who's pretty hardwired to be hypervigilant and actively resistant to relationships because they're seen as dangerous to the child. We reviewed in part one the adverse childhood experiences study. We saw that the abuses, physical, sexual, psychological abuse, can impact a child seriously. We saw that the family dysfunction of parental substance abuse, mental illness, domestic violence, an incarcerated parent, and the death of a parent can have severe and lasting neurodevelopmental impact on the child. As a result, high-risk behaviors are adopted. With high-risk behavior comes disease, disability, and early death. And we can see on the foundation and framework of adverse childhood experiences, and we see a disrupted neurodevelopment, high-risk behaviors, disease, and early death. The original studies found that with 4 or more adverse childhood experiences, a person would die 6 to 8 years earlier than the national average. Subsequent investigations have discovered that with 4 or more ACEs, a person will die 8 to 10 years earlier without intervention. Certainly that's the bad news. The good news is we have increasing awareness of ACEs. We have increasing awareness of the need for training of our child caring professionals in our communities and in necessary intervention. We feel in training professionals and in working with youth who have experienced trauma that some simple images of the impact of trauma and the impact on thinking can begin the process of healing. Any good disease intervention starts with patient education and increased awareness. From that foundation of understanding what the problem is, we can begin to understand and commit oneself to what successful interventions look like. So it's helpful to know what a normal brain looks like in a very simplistic diagram, so that we can see that at any one time an individual has all their senses firing, and as an organism is receiving an overwhelming amount of data through all 5 of those senses. In the bottom left of our diagram, we can see the sensory thalamus, our brain's traffic cop, which tells the information where to go. Typically, what's going on now and what's going on as you participate in this webinar is that the sensory thalamus is sending the information to your cortex, which is your brain's executive center of rational thought. You're connecting the information and making sense. That information is also going to your hippocampus, which is your brain's historian, so that when I talk about kids who have been physically, sexually, psychologically abused or exposed to substance abuse, mental illness, incarceration, death of a parent, domestic violence, you see actual kids and families in your hippocampus. How you respond to the world in response to the information coming in first gets filtered through your amygdala, and your amygdala is your security guard, and your security guard is always looking at the environment to determine if it's safe and if the range of responses that you've selected is going to be a safe and effective response to the community. What happens when a child is exposed to extended complex trauma? What we know is that the child, certainly during the earliest years of life, but throughout their brain's development up until and often through the age of 25 or 26, that what is going on in their environment is building their brain, building the pathways between different parts of their brain. What this image shows is a child who's exposed to acute and complex trauma, frequently responds by a direct feed to their amygdala, which is their brain security guard. And we know what the amygdala will stimulate in the organism when there is danger. We all know the fight, flight, or freeze response from an organism. And of course, that's varied according to the exposure to the danger, the level of danger, and the length of time that a child's exposed to danger. So what we see are very strong connections between the stimulus coming in and a triggering of the amygdala in an environment. And as any school teacher can tell you, we see that hypervigilance and that over-response to perceived threat, even in the safest of environments, even when those threats do not occur. Because of the connections that are built during these developmental phases, and certainly during phases of neuroplasticity, and that's basically when the brain is most likely to be influenced and repaired, early childhood and up until the age of 8 and in the preteen years. But attention and focus of stim to the amygdala in the brain, as you can see, causes weaker connections with the cortex and hippocampus. And the really sad news is that if you compare a brain that's been exposed to complex trauma for years with one that has not, in sophisticated imaging, you can see an atrophied cortex. We can see that there is organic impact of that trauma on the brain. That's the bad news. The good news is that we can effectively intervene if we can detect it through proper screening, and if we develop the people, the programs, and the systems that can effectively identify and intervene with the child in crisis. Where do we go from here? So what do we know? We know what the stages of treatment are, and whether we're talking about a treatment setting or a child welfare contact with the child and family, or a school classroom, the stages of response are very similar. Stage 1, stabilization, trust, and safety. How do we create environments where children who've been exposed to trauma feel safe? How do we help them feel stable, unchangeable, and unthreatening? How do we enhance their perceptions that the adults around them are trustworthy and safe? I always encourage staff in trainings to think about what you do the first time you meet a child. Think about what you do physically. Oftentimes these things come very naturally to us. We sit down, we get to their level, etc. We ask them what they're interested in. But as the relationship develops, we have to think about what trust looks like. Do we follow through on our commitments? Do we explain that things that seem uncomfortable and unwanted to them, such as placements, are instituted for their safety? So everything that we talk about has to reinforce trust, safety, and that we're stabilizing their environment. We'll talk more about stage 2, the trauma work. Our clinical providers are catching up and being trained in and delivering trauma-appropriate interventions in the clinical setting, and that we celebrate. Stage 3, learning to live in the moment. We can launch into a whole discussion of mindfulness, but with kids, how do we return joy to their everyday life? How do we reintroduce them to situations in which they can play? Because we know kids learn the best when they're playing in an environment. Response levels. We want to look at these 4 areas. Those who care for kids, our prevention, education, and treatment programs, where we're at, where we need to be, look at our agencies and our communities and systems of care as we move along. We still come across graduates of our social work programs, our teacher training programs, our counseling programs who have not been introduced to trauma, who have not had any introduction to the adverse childhood experiences research, and subsequently really can't see the world through trauma lenses as we need to. Traditionally, we teach our counselors and social workers and teachers and other professionals who work with kids to more clearly identify what's wrong with a child who's struggling in their environment. We have the Diagnostic and Statistical Manual, the American Psychiatric Association, devoted to figuring out what's wrong with a person. What we discover in our increasing awareness of addressing the needs of those individuals exposed to trauma is that the first, most effective, and most necessary question is not what's wrong with the person, it's what happened to the person. And when we can develop an understanding of truly what happened to a person, we can begin to design interventions. When we don't do that, we pull interventions out of a bag that's hung under the sign for whatever diagnosis, whatever problem we've identified. And those are most often not only ineffective, but can sometimes be very damaging. We need more addiction education, including the impact on the developing child. What we're doing in these last 2 webinars, talking about the impact of addiction, attacking the stigma related to addiction, is essential to more effectively deal with the children. If we're dealing with either a misunderstanding of addiction, the stigma that goes with that, if we're trying to understand how a mother could choose heroin over her child, that's going to get in the way of good care. When we understand that there is no choice in that disease until treatment is available and accessible, till we understand that, we're not going to be dealing as effectively with the family in general. We need supervisors who understand the impact on the caseworker, on the social worker, on the counselor working with kids and families, and on the teacher who work with kids and families in the midst of this crisis, who know the signs of secondary trauma, who can process. And most importantly, one of the things we know is the more prepared the responder is for what they're about to see or what they might see, the less the situation is going to impact them psychologically. So training, preparation, and possibly not responding to the worst situations alone in the field, so that there's some support system that's readily available during the crisis. And in general, the person is the core component of creating a milieu of safety, a sanctuary, so to speak, for the child and the family that enter our systems of care. Crisis intervention for those who care for children. It's important that when confronted with the crisis of a dead or dying parent, a child who's acting out in response to that we understand and can continue an ongoing screening and assessment of people's crisis response. To understand the crisis cycle, that as a person escalates in response to a real or perceived threat, the availability of their cortex and the availability of their likelihood of rationally responding to a situation lessens. We need a continuum of intervention. We all have a tool belt with tons of interventions. We need to be able to and learn to organize those interventions from least restrictive to most restrictive. The more that we gently sequence interventions on that continuum from less to more restrictive, the less likely we are to escalate the person, and the more likely we are to engage the person as we're not contributing to their moving along the crisis cycle more rapidly. Our non-escalating verbal interventions, we want to get really good at that initial response to an impending crisis. That's the engagement level. That we're not being directive, that we're all ears. We want to polish up our active listening techniques, our reflective comments. So many of us are problem solvers, and when crisis arises, we want to help the person solve the problem immediately. And oftentimes, without reflective kind of comments, without more understanding of how they perceive the problem and their readiness to address it, the less able we're going to be to get through that particular crisis with them. So from engagement to reflective kind of comments to gather more information. Supportive interventions during that verbal crisis intervention are important. We can get through this, we can help. And then finally, how we're going to protective kind of comments, how we're all going to stay safe through this crisis. What are our resources to help us keep safe right now while we're all feeling so unsafe? And we need a consistent problem-solving framework. How are we going to, after the fact, help a person review what the crisis was, what led up to the crisis, and what are some alternatives for dealing with it in the future? We need to get better at an ongoing assessment and screening. My community worked for several years at trying to develop a universal trauma screening tool. So the same form that every agency used. If you've ever tried to do that in your community before, you know how difficult that is. We finally gave up and we said, okay, let's use whatever form we want to gather this information on adverse childhood experiences. But let's enter it all into the same SurveyMonkey tool. That has been incredibly successful. We have a year of data. We know what the average number of ACEs are for females aged 0 to 17, for males. We know which ACEs are more prevalent by age, by gender, by race, which helps us to begin to understand our community. It's important that we begin to communicate our screening and assessment of clients to everyone. To present a problem with an individual or a family without first reviewing the history of trauma is not wearing very effective trauma lenses. To constantly remind ourselves to, before we ask what's wrong, to ask what happened in a person's life. From there, we can develop effective interventions. The intervention continuum is an example of how we organize our tools of intervention into a continuum from less structured and interfering on the right to the most intervention on the left. Now remember, this applies to, if we look at the physical restraints or the physical aspect, seclusion and restraint will be used by very few listeners in high intensity residential and inpatient program. It has to be used at times. But when we have a sequence of intervention tattoo on our brain, we can effectively approach an intervention with a person and ask ourselves 3 questions. 1, where will it end? So what do we predict might be the consequence of this escalating behavior if it's not effectively intervened with, or if it escalates too quickly? So, for instance, is a verbal direction to remove themselves from the situation what it's going to take? So where do we think it'll end? Second question we ask ourselves on the continuum is, where do I start? How many steps up the continuum do I start to begin the intervention? That's going to depend on the client's behavior. It's going to depend on their history. It's going to depend on the impact of the other people that are around during the crisis. But if we always start at the intervention that we know is going to stop the behavior, we've lost opportunity to engage, connect, and solve the problem with an intervention that's less restrictive on the continuum. So our first question, where will it end? Followed by our second question, where do we start? And our third question, how quickly do we move down the continuum? And that is simply determined by how the intervention we're using is working for the person. So that if I think a verbal direction is where it's going to end up, but a verbal reminder of the consequences the last time their unbridled anger took hold might be effective. So where will it end? Where do I start? And how quickly do I move down the continuum? This does several things. One, it puts a delay on our thinking. So oftentimes we tend to be reactive when someone's escalating. If we're going to, as every first responder does, a protocol for response that is structured, we're more likely not to contribute to the escalation of the person. We become predictable to the client who might frequently escalate. They begin to realize how we're going to respond and in what order. And third, using continuum, a protocol for response in a crisis, we can begin then to self-assess after the fact as we debrief. How did that work? Did I start at the right place? Did my interventions move along the continuum more restrictively as the person escalated, et cetera? And it's a language we can share with other professionals in terms of what works with the individual. As we talked about in the introduction to this section, there is a structure for verbally responding and intervening with a client. From left to right, this continuum goes, but it starts with engagement, being non-directive, how can I help kind of responses. Reflective responses, I tease that some of us get master's degrees so we can learn how to actively listen to people, but it's no joke. The better we are at active listening, the more we are attuned and connected to the person, the more they feel valued and listened to in the engagement, and the more information we gain in terms of what exactly the crisis is. Supportive responses, as we said before, we can help. This can be solved. This will work. So that positive encouragement. And then protective kind of responses. How are we going to stay safe here? So that when your local police show up to the crisis, there's no surprise, because I've said at least 5 times, well, the number one thing is we're all going to stay safe here. So we can go from there. And then how do we know when it's working, when we're intervening in a verbal situation? Are we making contact or not? How do we know if we're making contact? Is there a change in body language? Is their voice tone changing? Is their eye contact changing? And are we getting content or information. If we're seeing some positive changes in those 4 areas, body language, tone, eye contact, content, we're moving toward problem solving. If there's no positive change in escalation, we're eventually going to have to become redirective, closure escape, or possibly, and in the worst case scenario, a physical intervention from safety forces. But again, how we respond on a continuum in a crisis, how we respond verbally to our escalating client can make or break the therapeutic alliance that we create with them going forward. When I first got involved with this research and began to arrive at some conclusions, I called back to my own agency's assessment departments and said, hey, do we do any special attachment assessments? And there was silence on the other end of the phone, and the response was, like what? We have some standardized tools available to us all. Are we asking for these if we're a child welfare caseworker or a teacher when a child is assessed? But maybe the impact that we talk about of that sudden impairment of attunement in a parent and impact on assessment might move us to using more assessment tools in our assessments of children. And what those screening tools do and what those assessment tools do is not only help us learn more about what happened to the child, but it begins to sensitize all the professionals who work with the child when the first thing we talk about is the results of our assessment, our screening tools, and history of trauma. Parent education programs. We know there are evidence-based practices in this area. In Ohio, our Ohio Children's Trust Fund funds these evidence-based prevention practices and parenting programs. But frequently, when we create parenting programs for parents who are challenged in their parenting, we talk about things like how you structure your home, what your expectations are, what are consistent consequences that need to be meted out, positive and negative, for the choices the kids make. When maybe what our focus needs to be on is how to reestablish attachment, how to effectively attune with our kids, to put real simply, how to play with our kids again. That is most predictive of a return to healthy development for a child. So the slide shows some of the more effective evidence-based practices that we can use for parents. But again, we need to think out of our usual box a little bit in creating these parent intervention programs that we implement. What do we know and what do we learn more of since the redesign of our use of our prevention dollars in Ohio? Evidence-based programs. So at least we have a structure to look for outcomes instead of throwing money at things that we've always done. We know that home visiting programs are more effective. We know that that's how therapeutic alliances between professionals and parents and kids happen. And we need to learn how to do this. And we need to learn how to work up to that home visit. Because what we know sometimes is if we reach out, there's a discomfort with having that professional come into the home. The third bullet talks about some evidence-based practices for the counseling setting. Bruce Perry, who's an international expert on trauma in children, came to our community in 2013, and we had 400 professionals in the conference room at our medical school. And his first question was, how many of you are certified in trauma-informed CBT, cognitive behavioral therapy? And about 150 or 200 hands went up. And he said, that's so nice. Most of the time our kids aren't in their cortex. So his first line was, let's think about our trauma approaches with kids. Eye movement desensitization and reprocessing EMDR takes time, and but we know it's evidence-based, and I have yet to meet a counseling social work professional who's EMDR trained, certified, who can't name positive outcome after positive outcome with this approach. And as we're, especially in child welfare or in schools, referring the last bullet, beware of trauma certified or I'm trauma informed, drill down a little bit. What did that training consist of? And don't be afraid to look at outcomes. As I tell my own biological children, healthcare providers, behavioral healthcare providers that we access work for us. And so we should investigate what their qualifications are and what their outcomes are. Agencies, a culture of quality. I feel that our particular county and our agency benefit greatly from the data that we collect on the traumas in our clients' lives, and how we can most effectively address that systemically in our agency. If we know that there has been a large amount of mental illness and domestic violence, that's significant for us in terms of how we design our responses. It's significant for us in how we design our lobby. So there's every reason to do that. There are agency self-assessment tools. The last slide addresses National Child Traumatic Stress Network, a great resource for all things child trauma. So check it out. It really can provide some good interventions. Understanding dual diagnosis, understanding your own community's service delivery system. Are there behavioral health providers that are strictly mental health and don't deal effectively with a client who also has significant substance abuse problems? Are there substance use disorder providers who don't understand trauma? Simple questions to ask. And are we asking our clients what their experience is there and what's being developed? The vibrant team culture, being able to talk about not only the trauma histories of the clients, but our own response to the client. We come into this business with our own set of ACEs, and the only way we're going to be sensitive to how we're triggered is to talk about it. And I've worked with lots of teams who are able to talk about that in the format of a treatment team meeting. Getting client consumer input, that agency self-assessment that you can access through the National Child Traumatic Stress Network talks about, do you have client input into your policies and procedures, into how comfortable your lobby is? Do you look at the face that first greets someone at your front window in your agency? And is that the person, is that the demeanor that you want to leave an impression on a new client in your environment? We want to be well lit, clean, and safe. Those are kind of cliche, but when we look at it through trauma lenses, oftentimes we see things that we didn't see if we're just looking at it through business lenses or social work lenses. And constant talk about safety. What are the unsafe neighborhoods we might be asked to go in? How accessible are safety forces, security forces, when we have to deal with situations that are potentially unsafe? Our community, who's at the table? Trumbull County has a trauma-informed care steering committee. Stark County has probably been doing it longer than anyone, and they're always happy to talk about it. But if we can effectively get all the players to the table to talk about trauma, we can more effectively deal with families, because whether you're the police officer, a social worker, a caseworker, a teacher, Kids and families are involved in multiple systems, and we need to share the language. Our crisis intervention training for law enforcement in our county always addresses trauma, and it addresses it first thing, first day, so that we begin to think the same way. Our judges in family court understand trauma and the impact. So how do we engage, and how do we keep the dialogue moving at the table as we learn more about this? For more information, I find the National Child Traumatic Stress Network website a little bit hard to navigate, but I might not be the most effective navigator, but it really has everything there. The Child Trauma Academy, which is at the University of Houston, that's Bruce Perry's organization, has many, many resources. If you Google adverse childhood experiences, you'll find more information than you ever wanted to know. And for really updated information on the impact of this opiate crisis on children and families, look to the Public Children's Services Association of Ohio. Actively keeping track of that data and information. PCSAO publishes a fact book every year, which is available on their website, and is really not only the clearinghouse for information, but we design and promote and are creating a community of awareness of how our children's continuum of care needs to be reformed to meet the challenges ahead. So, wraparoundohio.org for part 1 for this workshop and for other related workshops. And as always, it's a pleasure to talk about a subject that's near and dear to our heart and is going to move us all forward in helping kids and families grow stronger in the face of huge challenges. Thanks for listening.